A little better. It's getting better. But just, you know, smiling and saying dada. And it's just, yeah, it's just awesome. So cute.
I went on spring break with my daughter. Week. She's coming home. Different weekend. I said the other day on the phone, I'm so excited to see this. We were just together 7 days. So what I hear in that message is she's had enough, and this isn't about you. I'm coming home to see Brian.
Right.
It's about Ryan.
Ryan.
Ryan. So I kind of had to laugh, and she let me know.
Sounds like she let you down easy.
She's a good kid that way.
Yeah.
It was great 7 days with her. Who's MS507? Why do I have this now? I don't want this.
Hey, Marshall.
You know, I think they connect, and then like we see them a second or two before, and they appears for them. A lot of times when I call them, like they're saying hi before I leave, and it even shows me on that.
Oh, Brian.
Oh, hi, Brian.
Brian.
Everybody stop talking bad about Brian. He's on now.
Oh, and it's Roxanne.
He still can't hear us. Hey, Marshall.
I'm Natalie from Richfield. Richfield. Richfield, hello.
Hi, everyone. My primary care provider is on the line, Dr. Hayes. So if there's any urgent protected health information questions about me that you have for Natalie Hayes, please feel free to ask.
I see you have 2 cookies, Cam. Do you think Natalie has an opinion on 2 cookies?
Natalie actually took borderline high cholesterol off my problem list, and I'm eating these cookies in celebration.
You can get something off a problem list?
I'm pretty sure these cookies are keto. Pretty sure. All right. MS 5072. Who's MS 5072?
Good afternoon. Debbie Anderson from the Poison Center.
Oh, hi, Debbie. Thanks for calling in.
Yeah, thank you.
I think Brian's making fun of us. You type in. I think we've caught everybody. Yeah. Kalog? Who's
Yes.
Kalog? Hi, who is this?
Hi, this is Kelly Logue. I'm with Health Partners. I lead our opioid improvement initiative, and I am not a clinician.
Excellent. Thanks. Welcome, Kelly. Let's see. I think we got highs to everybody. Lauren Anderson. Hi, Lauren.
Hi. Thanks for having me.
Yeah, of course. Thanks for calling in. So it's a little after 12:15. Maybe we'll get started. Just a reminder, in order to get you your CMEs and for us to know who's all calling in, if you could, chime in and say hello, or maybe even just use the Zoom group chat to give us your information so we know you. There's somebody calling in from a phone number. Last 4 are 1089. Not sure who that is yet, but I1089.
Hi, it's Natalie.
Oh, that's Natalie. She switched.
At Richfield.
Okay, so you're on
your phone. I
your
don't have
phone.
video on my computer. I'm here.
Gotcha. I didn't want to give out your entire phone number because I wasn't sure what kind of.
Thank you.
I don't know what kind of shenanigans that people on Echo are going to be up to today. So if you guys haven't noticed, I am not Brian Gran. He is calling in from Albuquerque. There he is, waving at everyone. So I'm going to facilitate here from our hub, and Brian is one of our spokes today. But he and Roxanne are in Albuquerque, and they're there now. And he is with Aw, there they are. Hi, guys. He's with the Little Falls team. All having fun. Hi, Rox. Heather, Katie, Kurt. Hi, guys.
Sorry, that was very mom-like.
Yeah. So just a couple reminders, the big one, no protected health information. If you could mute yourself on your end and then unmute yourself if you have a comment or a question, that'd be great. If you can't mute yourself, we can do it from here, but then that kind of slows down the kind of back and forth communication. So you can mute yourself on your end and then unmute when you have a question. You can even kind of raise your hand and flag us down that way, or send a message to the group chat, and I'll be kind of trying to pay attention to what's going on there. We have a couple of cases here. I'll maybe let Brian decide which ones he really wants to jump on once we get to the cases. But before we do that, we have Helen Wood, our primary care behavioral health psychiatrist, here to give us a talk on substance use and comorbid anxiety disorders. So looking forward to that. But maybe before we do that, I think we've said hi to everybody that's popped on.
Number is 443.
Yeah. Okay. There's a phone number, 6747. Hi, 6747. Hi, Lene. Frostbite Falls. I get what you did there, Kurt. Waka waka. Yeah. So a couple of updates. You should be able to see what our upcoming echo sessions are. We have OBAT and 254G or OBAT talk from our very own Nate Erickson here. We have a talk on medication disposal coming up on the 28th. So stay tuned for some of those. We have Nicole Konsanke, Dr. Nicole Konsanke, I think I'm saying that right. Brian can correct me if I butchered it, who's going to be talking about the community reinforcement approach in family training, or CRAFT. Dr. Ann Pilkus is going to come back and talk to us again about high-dose tapers and transitions with buprenorphine. Dr. Nelson, Kaz Nelson, is going to be talking to us about BPD, recognition and management of borderline personality disorder. And then we're going to get on the 25th of April, so about a little over a month out, we're going to have Ann back to do a second part of her high-dose taper and transition to bupe talk. So maybe before we get started, we'll just quickly go around the room here and say who we are, and then we'll go from there. So we have a new guest with us today from Pain Clinic. If you want to introduce yourself.
Galani?
All right, Galani, DMP
Yes.
with the Pain Clinic. Okay, great.
Helen Wood. I'm a psychiatrist. I help out in primary care clinics doing psychiatry consults to help family practice doctors manage psychiatric issues in a primary care setting.
Cool. And I'm Cam Weaver. I'm a clinical psychologist, also working in primary care behavioral health. I serve as our coordinated care center clinic, as well as one of our internal medicine clinics here in downtown.
And I'm Nathan Erickson. I'm an alcohol and drug counselor working in the addiction medicine clinic here at the hospital, and then with Hennepin County Drug Court.
And Stephanie,
I'm Stephanie Dean. I oversee the CME program here.
She's a little off camera right now, but she is our CME guru.
Yep.
All right, and then we have some guests with us. You guys want to introduce yourselves really quick, please?
I'm Katie, internist addiction medicine.
And my name is Elizabeth, and I work as a scribe at HCMC.
Okay. Future addiction med / psychiatry MD someday, which is what brings her here. All right. And there we go. Thank you.
Thanks, T.
Now it's T working the camera. Okay. So Brian, anything you want to say before we get going? Anything I ruined?
Our camera's on.
No, I think that sounds good. I think just a reminder for anybody who has multiple people in the room, if you could send us a list of who all is in the room so we can track your participation. ECHO is really built on trying to touch 1 billion lives or until 2025. So we're really trying to help and understand who's participating. So please send us that information, and then we also can then vice versa try to reach out to see how we can help you guys out. And after the presentation, we'll kind of have a little bit of a debrief before we get to the discussion. So thanks, everyone, and happy to be joining you here from Albuquerque.
Okay, great. All right, so without further ado, I'll turn it over to Dr. Wood.
Hey, It's Helen here, and I have nothing to disclose, and I want to shout out and say hello to another Helen from North Point, welcome, and someone else from Assemblage Neighborhood Health Source Clinic as well. And Dr. Corser, welcome. So do I just click this?
This one.
This one?
Yep.
Okay. It's always fun to start with the case. I struggled to think of a case when Brian asked me to talk about substance-induced anxiety disorder. But I did remember a cheerful medical student about in the second year carrying around a big Robbins pathology book, driving down to the U Saturday morning for an exam. And a kind person noticed I was a little jacked up. And said, how many of those coffee drinks have you had? And I said, well, this is my second. And they noticed I was carrying a can of something else, which is the Mountain Dew. And they said, how many of those have you had? I said, well, I've already had one, but this is for my next one. And that was really the first time I observed the interaction between caffeine and anxiety. So luckily things went well, but I detoxed myself off of or titrated down the caffeine, and I felt a little less anxious about some of these academic issues. But when we think about substance-induced anxiety disorder, the essential features are that there's a real prominent anxiety or panic that's due directly to the effects of a substance. We really look at timelines when diagnosing substance-induced anxiety disorder. We want the onset of symptoms to be during the exposure, and it quickly remits as soon as you stop using that or the substance wears out of your system, it goes away. If the symptoms persist for over a month, we really have to look at other causes for those symptoms of anxiety or panic. So there can be anxiety associated with intoxication. These are substances that are listed in the DSM-5. This is not a comprehensive list, and I'm sure we can all think of others, but just to give you some examples there. We also have anxiety that's associated with withdrawal. I think we all see this commonly with alcohol and opioids and sedatives when we're coming off of those, as well as specific medications. Again, these are listed in the DSM-5, so you can quickly reference them if you need to. I had a case in clinic the other day where I was asked to consult on a young lady with anxiety and panic disorder, and she was using albuterol to calm herself down, to take a deep breath, and felt calm after that. However, was having splitting headaches and had a new headache disorder. And she had no diagnosis of asthma. And so my consult was maybe dial down on the albuterol and see if that helps. But I felt like that was reinforcing for both the anxiety, panic, and headache. So we'll see how that case resolves. But I thought that was interesting. Interestingly, they list the psych medications, anticonvulsants, mood stabilizers, lithium, and antidepressants. And I started to think, are all psychiatric medicines having anxiety as a side effect? And I really question, especially having antidepressants on the list, because I wonder if it's really akathisia. Now, I do know what it is, even though it appears I can't spell it correctly for the slide. I apologize for that. But akathisia is a sensation of restlessness. So a subjective experience of restlessness that happens anytime you use a medication that antagonizes dopamine. And we see this with antidepressants as they have inhibitory effects on serotonin, which acts in that way. So a lot of patients have trouble when they start an antidepressant especially, and I wonder if it's akathisia. They don't have that vernacular necessarily to describe that, and they may think they're experiencing restlessness, but oftentimes if we decrease the antidepressant or use a little beta blocker to treat that, that will go away, and I would not consider that anxiety, but rather akathisia. Toxins, sarin gas, which we all know about from watching Homeland, volatile substances can cause anxiety as well. And what is the prevalence of substance-induced anxiety disorder? So standing alone as an entity outside of other diagnoses of anxiety disorder, it's really not clear. As a standalone independent diagnosis, it seems to be pretty rare. And per the DSM-5, they're listing this really low 12-month prevalence, which may explain why clinically I'm not coding it out or diagnosing it and have trouble even thinking of a case recently. The best paper I found trying to describe prevalence on this is drawing from the NESARC data. And that was really talking about independent mood and anxiety disorders, and also asking patients about chemical use, chemical treatment, and trying to tease out the prevalence and incidence of those. And they're really, in this paper, they were really talking about the associations between substance use disorders and independent mood and anxiety disorders were overwhelmingly positive and significant. And only a few individuals with the mood or anxiety disorders that were classified due to only substance-induced anxiety disorder were there. It was only a few individuals. Everything else was so highly comorbid. Again, what I found interesting, I'd heard about NESARC before, I've studied it before, but it's really interesting to go through methodologically. It was a U.S. sample of 43,000 respondents. It was face-to-face interviews. They had 1,800 people interviewing patients. They had supervisors calling back 10% of the interviewees, double-checking and reviewing the interviews, validating them. So quite a component on integrity for this. The target population was civilian, non-institutionalized people living in the U.S., and they included Alaska and Hawaii. They included some group quarters like group homes, shelters, boarding houses. They didn't include people living in prison, hospital, or jails. They had an 81% survey response. They oversampled Black and Hispanic people as well as young adults. And so this is interesting because with this study, we've got data from persons that are usually underrepresented. So I thought that was just really lovely and interesting. And it was also the first time they used the DSM-4 criteria to really diagnose substance use disorders, which was a real departure from previous where we had trouble nailing down, is it due to substance or not? And I think
a whole paradigm shift, really.
Right, whole paradigm shift. And I think really influenced kind of how we look at this. Here's some interesting statistics. You guys can read that. But the conclusion from this paper, which is why I think it's so important, is they drew this result that the results strongly suggest that treatment for a mood or anxiety disorder should not be withheld from those with substance use disorders in stable remission, assuming that most of the disorders are due to intoxication or withdrawal. So I just think that was a revolutionary paradigm shift and approach to looking at getting patients good treatment for their mood disorders in addition to treating the substance use disorder. So that diverges from what was historically going on in the field. Whereas a psychiatrist, we would focus on mental health symptoms and ignore addictions. I've heard it commonly expressed back in my training, even some attitudes about, oh, well, we'll worry about your depression after you get sober, because certainly that's causing this. Or in chemical dependency treatment in the 60s and 80s, that depression would be an excuse of why you're not sober. And so I think this paper brings to light the fact that the comorbidity is the rule, not the exception, and we should be treating these things. So if we go to the DSM-5 and look at the strict criteria, this is what you're going to find. So the panic attacks or anxiety predominate the clinical picture. There's evidence that the symptoms evolved right after using the substance or soon after intoxication or withdrawal. You can't explain the disorder by another disorder, anxiety disorder that isn't substance or medication induced. It doesn't pre-exist this. It does that. The disturbance or symptoms don't occur during delirium. And then the functional impairment criteria. So we see this with almost all of our diagnoses in the DSM-5. There has to be significant functional impairment to be able to diagnose something. We see patients commonly that have symptoms of anxiety or insomnia, but they may not have any functional impairment associated with it. And so we would not attribute those symptoms as rising to a level of diagnosis. So important. Yeah. Okay. Again, symptoms should predominate the clinical picture and be severe enough to warrant clinical attention. So how would we know if there's an independent anxiety disorder? Well, historically, we're using a timeline type of interview. And so we're looking at symptoms that would precede the onset of the substance or medication use. And we think of the case, especially that Alex presented last week, where we had a gentleman who had really severe chemical use, but in that timeline, there was about a 13-month period where he had abstinence or sobriety. And so what we would want to do is try to figure out from the patient or collateral information from friends or family if there were mental health symptoms during that 13-month period of sobriety to establish whether there's an independent diagnosis, in that case of a psychotic disorder. The symptoms would persist for a time after cessation of use or the drug is worn off within the system. So if we have symptoms of anxiety that persist over a month, we're thinking, boy, that is really suggestive of an independent anxiety disorder. And this is likely not solely attributable to the use. Or a history of recurrent episodes of anxiety or panic that weren't related or did not have concurrent chemical use during those symptoms. What are approaches to treatment? How do we treat this? So the first priority is always to treat the chemical use. A lot of times our treatment involves medications that actually will help reduce anxiety. For example, with opiate use disorder, we'll use clonidine and gabapentin to help with some of the symptoms of withdrawal, and both of those medications help with the anxiety as well. So what happens to the anxiety if we treat the substance use correctly or we get it under control? A lot of times the anxiety will improve. We also want to look at that careful history and look for timelines and periods of abstinence and inquire about baseline symptoms. And if the symptoms persist, you have good treatment for the substance use, but the symptoms of anxiety and panic persist, then likely we have an independent disorder that exists and it warrants treatment. And we know these are highly comorbid. Think of Charlie's talk where he pointed out that 45% of patients on medication-assisted treatment are concurrently prescribed a benzodiazepine. To me, that suggests we have undertreated anxiety disorder in those patients. That makes sense. Remember Dr. Hockey's talk where he talks about opiates impairing and not just, or diminishing not just physical pain, but also psychic pain. So if we can't touch our psychic pain, how can we treat it? So this all makes sense with the things we're learning week to week. Now, I don't mean to drive anyone to drink here by putting this up. This is actually the coding page out of the DSM-5 for coding out substance-induced anxiety disorder. I know it's a hot mess, but look it up. You don't have to memorize it. I certainly don't. Just a couple things to point out here. The far right column is where you're going to go to code out an independent substance-induced anxiety disorder. So per DSM-5, they really want us to code in terms of whether or not there is a substance use disorder. So if someone has just a substance-induced anxiety disorder without substance use disorder, you go right to that last column and you can see the fourth digit there is a 0.9. That 0.9 indicates it's a standalone substance-induced anxiety disorder. So first you would identify, do they have a caffeine use disorder, mild, and then with the substance-induced anxiety disorder, then, and that would be that first column, the F15.180. So always determine whether they have a substance-induced substance use disorder and what level of disorder that is, a severe, moderate, or mild. And then if they have the substance-induced anxiety disorder on top of that, it all goes together in one neat code. So theoretically should make things easier, but it looks kind of like a mess when you're looking at this. And again, there are specifiers for onset during intoxication or withdrawal or after medication use. So I'm sure there's no questions about that. Totally clear. And then here's my sources. And so again, this is kind of a short and sweet talk, but the paper is really interesting and I encourage you to look it up if you want to learn more about this NESARC methodology, which I think is really fun to look at and exciting because they interviewed so many people and did it so thoroughly and did such a great job. So, all right, if there's any questions, I'll take them. Thank you.
Thank you, Helen. Any questions for Helen Wood? Yeah, Marshall.
Helen, thank you. Very nice. I've had a few patients who described anxiety that went on for months or even years after teenage or young adult use of marijuana. And I kind of thought that was one of the things that you might talk about today. But you seem to be saying that the criteria for the substance-induced anxiety disorder that you're describing today has to be, less than a month, has to be more in the time period that the substance is being used, not lingering for a long time afterwards. So
Yeah,
something different?
Yeah, I think that's right. I mean, I agree with you. I've seen people who've tried a substance and then they've had panic attacks years later, and I can't attribute it to whatever substance they use is causing the ongoing, but maybe lowering a threshold, or they had a vulnerability to it. So I think with your young lady, she likely has independent anxiety disorder, and maybe it was unmasked or unleashed by the use of the marijuana.
Yeah, I mean, I think, and specifically in the context of panic disorder, really all it takes is someone to misattribute those bodily sensations to something threatening. And so whether that initial panic disorder was triggered by kind of the tachycardia or something might come along with marijuana use, if from that point on in the future, they are attributing those similar uncomfortable bodily sensations as to mean something threatening, you're kind of setting the stage for a panic disorder down the road. Good question.
So you're saying that that what I observed in these two cases, I guess, was probably somebody with an underlying anxiety disorder that they were not symptomatic of, or that just hadn't emerged to the point where they wanted to discuss it. But it was brought out by their relatively few episodes of trying out marijuana.
Yeah, and but it might be, I think what Dr. was saying, correct me if I'm wrong, is that it could be independent of that as well. It just might be that whatever symptoms often things like panic, they kind of start with the first panic attack, however that might come on. So it might not necessarily be some like genetic predisposition that is expressed due to like this, teratogen or something. But it could be.
Hey, we have a question from Brian, and he said, for what reason do you need to code that specifically versus anxiety unspecified if you don't know if it's substance-induced versus other anxiety disorder? I think that's a good question, and sometimes we don't know, and time will tell. So I think within that first month, if it looks like the anxiety is what we would expect as a normal part of withdrawal, I wouldn't code it specifically as substance-induced because it's expected as part of it. But if it's hard to know.
Do you know if including substance use disorder as a part of the diagnostic picture, does that increase like the complexity from a billing standpoint?
Probably. I mean, this is a tricky one to code out, which is why I put that up there. But they would want all of the specific substances: cocaine, caffeine, methamphetamine, all of, you load up as many as you can, and they're trying to just be very specific.
There's no polysubstance use disorder in the DSM anymore. Yeah.
Yeah. Did that answer it, Brian? I'm not sure.
You're Brian, you're muted.
We can't hear you.
The teacher has become the student.
I can unmute him right here.
Kurt, could you just give him a...
It's unmuted.
No,
Brian's still muted, Brian.
Unmute.
Unmute.
No.
Oh,
Nate, I think you muted Brian.
No, I didn't.
I mean, for good reason. Brian, you want to come over here and ask a question?
all right.
Am I still muted?
No,
you're good. We got you now.
Quit swearing.
Watch your language.
Yeah, you guys muted me on your side. I've been unmuted the whole time. So to my point, actually, if I hear what you're saying from a DSM, and maybe that's in private practice, but in any EPIC system, it's just listed as substance-induced anxiety or anxiety unspecified. And so there's no kind of coding, just for the clarification, if you have EPIC, that's what you're doing. You don't have to do it by substance specific. It's just kind of substance-induced anxiety, and that's how it's generally coded. So I wouldn't stress too much about that from a coding perspective. I know lots of times it's really, especially in polysubstance, it's really hard to tell.
Yeah.
One thing I was curious if you could follow up on, the one comment on Marshall's, also that the onset of adolescent substance use is oftentimes exactly correlated at the time of the onset for most anxiety disorders, like generalized anxiety disorder, panic disorder, oftentimes manifest around that same kind of late teen time frame. So oftentimes people attribute it to substance-induced, then it kind of progresses and it's still, they just have an underlying anxiety disorder. At least that's what I've seen. I'm curious your thoughts, Helen. And I'm curious if you would treat it any differently. So if you're starting to treat somebody, stabilize them on buprenorphine, they have anxiety, would you still start, if they're having anxiety, would you start like an SSRI or buspirone, or like pick your anxiolytic?
Yeah, good point about Marshall's case. So the onset of anxiety disorders, we rarely see younger than teenagers. So we think of teenagers and older. So in fact, one of the sources I was looking at said that anxiety disorders are really overdiagnosed in young children. And a lot of times that's more trauma symptoms. But for adults, we're seeing the average age of diagnosis for anxiety disorders in the 30s, for example. We see it more prevalently in females than males. When to treat anxiety disorders in the context of starting someone on buprenorphine, it's a good question. I like to get someone out of the acute withdrawals and get them stabilized onto the new medication and to see what they're tolerating and see what dose they need. And then once we get stabilized from that, and that varies by person. So some people I've seen stabilize really quickly in a couple of weeks. And then if they still have prevalent anxiety, I don't wait 2 months to start something. And I like to start an SSRI. And in fact, I found many of my patients who were resistant to starting an SSRI or an antidepressant for treatment of anxiety, who I have had on Suboxone for years, once I was able to treat their anxiety, I was actually able to decrease their dose a little bit of the Suboxone, and they had more energy, they felt more mental clarity, and they in general felt better. And so I think good treatment of anxiety is really helpful, and patients, I think, really don't want to acknowledge they have anxiety. Like my experience is they're fine with taking buprenorphine, but they really, they're resistant to a little duloxetine or sertraline, which is always surprising to me, but I do find it helpful.
Great. You're getting at a question that we were getting from. So just before I ask this question, there is a conference room full of people. I don't know what the thing is, but just so every single person around that big conference table gets their CMEs, if you could, they already did it? They sent you all the names? Perfect. Okay, so their question is, we seem to see prolonged anxiety in people who have used methamphetamine. It often seems refractory to treatment. Are there different treatment strategies for anxiety caused by substance use disorder? And then you kind of got at this a little bit. What are some of the most successful treatment strategies for anxiety that are not benzos? Which SSRIs or SNRIs do you choose?
Oh, boy. No controversy there.
Yeah.
So I did not find anything in the literature about specifically treating anxiety that occurs only during substance use. So a true substance-induced anxiety disorder that will resolve once the substance is out of the system. So I don't find good data for that. In fact, the trainings that I've been through addiction psychiatry have said there's no indication for additional treatment for that. However, I do note that many of our treatments for withdrawal protocols for alcohol or opiates include medicines that help reduce anxiety as well. So I think just getting good treatment for the substance use is the mainstay of treatment. I believe the second part of that question was prolonged anxiety after methamphetamine use. Mm-hmm. And I guess I've seen that. I'm not sure of any specific literature on that, but I think I wonder about cravings contributing to anxiety, mm-hmm. and people misinterpreting cravings as anxiety. And so I look at strategies to treat cravings and trying to tease that out. But I also look at, mm-hmm. psychology and augmentation with CBT and social support and things like that. In terms of which antidepressant to start, totally based on side effect profile, patient's history of tolerating or intolerating those medications, family history of being successful or not successful with those types of medications, making sure they don't have bipolar disorder or another type of mental health symptom that would require more substantial treatment. But most SSRIs are very well tolerated. They're not going to cause anxiety. Again, they can have some side effects, but those are usually well managed, especially if you start with the low enough dose and titrate it up slowly and have frequent enough appointments to reassure the patient that they can get better.
And from a behavioral perspective, treating the substance use disorder first can be very important because the substance use itself can become an avoidance strategy, and treating anxiety is all about approaching the things that make them feel anxious. And so if they're actively engaged in substances that help remove anxiety, even if it's temporary, is kind of runs contradictory to the treatment strategy that psychologists use, which is usually an exposure-based paradigm. Tends to be the most effective or at least the quickest.
Right, and for that reason, I tend to not use a lot of benzodiazepines when treating anxiety because I think it interferes with their ability to engage in successful psychotherapy, which is long-term what's curative for anxiety disorders. And
Brian, looks like Brian's got a question. Or a comment?
Actually, a quick comment, and then we should probably just move on to a debrief and then a case if we have time. But just one comment on that. Sometimes if it's a methamphetamine-induced like paranoia, which would fall under like a psychosis, that is treatable with an antipsychotic. So I would not necessarily hold off in that case. Oftentimes, if it's persistent for meth-induced psychosis, an antipsychotic is appropriate for even a few months until it resolves. But depending on kind of where the driver is from, their medications can be appropriate for that. Be really helpful. Transitioning a little bit, if you have any questions, please feel free to just send us in and we can kind of respond to you offline. But I'm just mindful of time. I want to take a few moments here before the 1 o'clock your time hour hits. And I know many people have to take off for patients. I want to just take a few moments here is we're at this Meta Echo conference talking about echo sessions worldwide. And one of the things that continues to come up for lots of folks is just how to get the right information to you in the community that you're really looking for. So we're trying to be pretty responsive, but I just want to open up to a forum both for saying, like, how can we help support you, in particular getting cases? I know many weeks we're kind of sending out emergency last minute, like, help, do you have any cases? And I'd love for there to be a better discussion amongst the cases that you're seeing in your community. Thank you to those of you who have. How could we help support that? Because I'm sure that you're seeing complicated, difficult patients in your practice. And as much as we can present our cases, I think it's really helpful for the dialogue at large to really make that more of a conversation. So I guess questions to throw out to the community, I'm curious your responses, is one, are there things that you wish we were doing more of that would be more helpful to you? We've thought about switching the timing of the case presentation with the didactic. Would it be more helpful to do the case presentation first and then the didactic? Or is there something that, like, is there other ways that we can help support you so that you can present cases that you're seeing in your own clinic? So I just wanted to throw those questions out there and see if anybody has responses, or how can we help support you better or differently?
Brian, I believe that Echo is universally loved by all of our listeners. I can't see where there would be room for growth. We're nailing it. What do you guys think? Helpful? No? Okay.
Well, that may be the case. I guess I'm particularly curious on the line of how can we support you for your case presentations? I don't know if it'd be easy for people to sign up for some. We can just kind of throw out a couple dates for the next several weeks if people would be willing to present a case that you see in your own clinic. Again, it doesn't have to be specific to a person on buprenorphine or a person with an addictive disorder. It may even be a difficult pain patient where you're struggling with what's the right dose of opioids. So I think that's probably what we will default to if I don't hear any other ideas. But I know that's something that we're just kind of looking to see how can we help you and think through your own cases, because ideally this is mentoring and helping you kind of get better in your practice.
Hi, Jim. Yeah, please.
The one thing I thought of is that sometimes when we have, when we're commenting on the cases, we run short of time, and there's only so much time. So I wonder if it'd be possible to sort of submit an idea or a thought or a suggestion after the case is over, and that could be like a this in substance use, and we have
Jim
didn't get a check what was on their mind. Beginning of
Hey, Jim.
Type of email comments.
Are we delayed too?
I don't know. We might all be experiencing something. Hey, Jim. I think I think we got the remix version there.
We had to break it up.
Yeah,
a little bit
you were buffering there towards the end. I'm not sure if it was on our end or yours, but
you started, Jim. We got the part about wanting to continue the discussion in some way, or leave your thoughts after maybe the echo's over, like a place to sort of leave our final thoughts or things we didn't get a chance to add in.
Yes, and I'm thinking just take 2 minutes for anything that people have submitted after the echo session ends the following week.
Oh, okay.
Good feedback.
That's great. Yeah.
A wrap up.
And to follow up on that, would it maybe be possible to send out the cases prior? So if we do have questions, we're ready for them?
That's a good idea.
That's a good idea.
If we had them in advance.
Yep. I think if we're getting the cases in advance, for sure. Nate had a great idea for getting more cases from our ECHO community. Did you want to?
Oh, well, we did have that contingency management education stuff. If there's any incentives we can provide?
Yeah, we can figure something out, a little prize bowl scenario.
Fishbowl?
Say, Cam, I think, in Little Falls, we use torture, the possibility of torture, and we get a lot of cases because of that.
That's good.
It's not well accepted in the urban clinics anymore.
Yeah. They get tortured by having to share an office with Kurt for a day.
And so responding to Alyssa's comment, can you remind us how to submit? Anytime that you have a case that you're interested in, you can send it to Roxanne. So roxanne.kibben@hcmed.org or hcmc.opioid.echo at hcmed.org, where you kind of leave it on our website. And there's a brief case form that we oftentimes use. It takes just a few minutes of time. And oftentimes if we don't have all the answers, that's exactly why we bring it up, to kind of think through when do you need to add more or know more, or how would other folks be framing it. So if you have any cases, please feel free to share. I know there's a wealth across the state.
And we have a question from Alyssa asking us to just kind of give a reminder on exactly how we can, how you submit cases. So it's simple. If you have a case idea, let us know. Roxanne would email you our case form, which I don't know if you can see it, but it kind of looks like this roughly. It's less blurry up close. And you would just fill out the form and email it back to Roxanne, being mindful of not including any protected health information, and we'd go from there.
We have to get to the case. We have one question from Haley, but do we need to get to the case?
Okay, and we have one more question from Haley, then maybe we get to the case.
I can totally wait. You can go on to the case.
Okay.
Oh, okay. All right.
We'll
okay.
get to that.
If you wouldn't mind, we can take your case. Probably You can do patient J.
Patient J. What's the age of patient J?
28.
Okay, got it.
Hello.
Can you post
Just a reminder, if you're listening in, mute yourself on your end, because once you start talking, you kind of take over the screen. So, okay, Bride.
And can you guys put the case presentation form up, or I don't know if that's possible. There you go.
Okay.
So the consult question at the end of the day is really, it's partly about social support and what resources people may have in different parts of the state, or how you kind of figure this problem. But two, in terms of managing comorbid opioid and methamphetamine use disorder. He's got some other marijuana issues that I think are interesting as well. But this is a 28-year-old gentleman who's been with us he first started a little over a year ago. And he has a history of social anxiety, possibly generalized anxiety disorder, IV drug use, opioid use disorder with IV heroin, marijuana with maybe a cannabis use disorder, and methamphetamine use disorder, who first met with us, started on buprenorphine with naloxone after a hospital admission for meth-induced psychosis. That gradually resolved. He was on quetiapine for about 3 or 4 months before that fully resolved, and then he's been off of it since then. And then he was actually doing quite well, although he was bored. He lives with his parents and has for a long time, has struggled to get a job. And then he eventually kind of ended up dropping out of the clinic, just stopped showing up. He had relapsed to IV methamphetamine. Interestingly, shortly after he had tried to cut down and stop his marijuana use, he said that really his go-to for coping with methamphetamine cravings and anxiety has been his marijuana. And as he's been through different treatment programs and heard the word that he really should cut down and stop his marijuana use, he's really struggled with the methamphetamine cravings and inability to cope with that. So his IV methamphetamine use kind of escalated, and he ended up relapsing back to heroin. That scared him. It kind of an overdose that didn't result in naloxone. That freaked him out. He came back to the clinic and re-engaged in buprenorphine with naloxone, Suboxone treatment. He also engaged with the day treatment program. So we've got like a to run through psychology and psychiatry at Hennepin, but it's kind of like an intensive outpatient program where it's a few hours, 4 days a week in the mornings. And so he goes to that to kind of fill some of his time. But even while he's been there, he stopped his marijuana use about 4 weeks ago now. But in that time, he's now started relapsing back to methamphetamines again. So during the week, he's generally pretty good. But then come like Friday and over the weekend, we've got a lot more downtime and boredom. He almost inevitably ends up using again. Most of his friends are still actively using. He lives with his parents, which he hates, but hasn't been able to find a job. Last summer, he had a job in a car wash, but since then, he hasn't been able to find anything. He's been eligible to get kind of different labor jobs, but he's really scared about doing that because the only time he's ever been seriously injured was when he was working at a Parks and Rec landscaping job, and literally a very large tree limb fell onto his head and neck, and he had some neuropathic pain that since been become well controlled, but that really, he struggled with that for a long time. So now kind of the big issues for him, occasionally he comes in and he'll have injection marks on his forearms, but he hasn't had any abscesses, cellulitis, or any other complications of that so far. He gets his needles from a Walgreens, so they're all packaged, so no concerns about infection from that perspective at this point in time. But really the kind of the questions that come up that are still a struggle are really a lot of this methamphetamine, I would argue, is as much driven by boredom as anything. And so it's kind of this question about, he's tempted to go back to marijuana use to try to suppress his methamphetamine cravings. At the same time, he feels like he's finally cut out 2 of the 3 substances that he used for a long time. So he's actually really proud that he stopped his marijuana use, but now he doesn't know what to do as a next step. So kind of the key clinical questions to think through. One, any suggestions that people have about how to engage people that are really struggling to work or get busy during the daytime? And then two, any thoughts on the marijuana versus methamphetamine question?
Maybe we'll kick this out to the ECHO community first. Any thoughts out there? Any clarifying questions you might have? Hi, Jim.
I would comment that approximately 50% of the patients I see are positive for cannabis, and then positive for boob, and generally no other substances. And that doesn't seem to affect their ability to come to clinic and do pretty well. So I see the cannabis as much less of an issue than would be meth. Thanks.
Thanks, Jim.
Yeah.
What about something like, I mean, since he doesn't have financing for housing, I was thinking like a structured sober living. Otherwise, there's Minnesota recovery programs in St. Paul that are all about getting out in the community, getting that structure and support on the weekend that maybe he doesn't have to keep him distracted.
Okay. Were you guys able to hear that? Okay. So the thought was in St. Paul, there kind of something. There's the Minnesota Recovery is a program that is kind of focused on increasing functionality and getting kind of people out and engaged in some of those things that they maybe would otherwise enjoy, and then maybe some structured, supportive, like sober housing. What was the thoughts?
The comment that I have that he's really struggled with is that he's willing to go into this day treatment program that's run not as a CD treatment program. He doesn't want to go through a Rule 25 assessment because oftentimes he feels like he's been burned to go to residential all the time. Where he goes to the mental health program, not a CD program. And so as a result, then he's not eligible for most sober housing because he's not completed a formal treatment program. So that's a sticking point that we've had and one of the struggles that many folks looking for sober housing has had. So I don't know if Valerie, if you have any thoughts from Minnesota Recovery or if anybody else has had that issue that you found to work around.
Do you want to address that?
We have 3 recovery navigators on staff who help people with those exact issues.
Okay, great. And then we have a comment that let's see, the environment's definitely a problem. He may need a job coach and a strong interest inventory assessment. Also, to kind of get him more busy on the weekends.
There's some lists online of free things to do in Minnesota. If you look up free things to do, I think he said something in his comment about a 99 free things, but there's great lists of things to do in the metro, in the Twin Cities that are free. So that's always a fun thing to provide to people. You want to go, Helen?
Oh, sure. I was just going to say, because he fell on his head, I wonder about work capacity and what type of job would be the best for him. And I think about the role of neuropsych testing and elucidating that a little bit, if he's open to that.
Yeah, Florida, he hasn't really had much interest in following through on really anything. You want to identify other activities. I think it's that struggle of the people that say they're really bored, they really want to do stuff, and then you offer stuff to do that's available, and then there's no follow through. So I think it's kind of the lethargy of how do you get them activated. And I think that's where I'm struggling.
Well, and I think that marijuana can contribute to some apathy as well. And so I like that he stopped using the marijuana. I always wonder about a little bit of subclinical depression symptoms in this case. He's on Prozac. He smokes cigarettes. Would there be a role for Wellbutrin as being helpful in reducing a little bit of depression, helping him get off the cigarettes, which I don't know.
That's a question.
Yeah.
What is the relationship with his parents? He lives at home. He's 28.
Okay.
Are they?
Stephanie's got a great question about the parents and the fact that he lives at home. Brian, do we know much about the parents or the home situation?
Yeah, so it's like the place where he can go where he's not on the street. So his parents have welcomed him back into the home, but they essentially exclude him from any family activity. So recently there was like a big family vacation where his brother and his parents went on an annual vacation out west, and very specifically said, like, you're not coming, don't ruin the house, and left. So he gets, when that happens, he gets in a pretty significant depression.
Sure.
It's very situational. But I think it's, again, to that question of, like, when's the right time for medication versus family therapy, but, like, are they going to engage? They've been really burned by him because he's had so many use episodes and you know, formal treatment cycles, and that's why he doesn't want to go back to any program. He's like, I've been through the, you know, the ringer. So there's no point.
Brian, what was his kind of pre-morbid interests? So prior to onset of substance use, no matter how far back you have to go, was there a time when, you know, he really liked playing AAU basketball, or he was in Little League, or he used to play tennis or golf or chess or anything? Is there anything, can we go back before substance use and say, yeah, when I was little, I used to do these things? Even though it seems silly, that's often a great place to start if you're looking for a foundation of, like, pleasurable events to get him involved in.
Yeah, I think he does to try to avoid going home in the summers. He loves skateboarding, so he'll, like, hang out at the skate parks for hours and hours and hours, just because he hates going home because he doesn't like the family dynamic. But then it's the question of, like, he still doesn't have any other people that he hangs out there, because he just is kind of like a loner. And then somebody calls him for a ride, and then usually they pay him with meth for the ride, and cycle returns again.
Is your interpretation that, like, one of the kind of motives for use isn't just, like, coping with anxiety, but there's also, like, a social enhancement motivation for meth use? Like, that's where, if he's socially anxious, that's where he can kind of get more involved in those social situations, gets access to people.
I don't know if I'd quite say that, but I think it's, he's just really bored. And then people just offer to him, and he's like, well, why not? So oftentimes it's like this absence of other activity where it's really trying to, behavioral activation is really a big deal for him. And trying to figure out where to go. And so, you know, Match.com is, as folks just brought up, might not be a bad option, but I think it's a struggle right now for him.
It's a bad option, Brian.
So that was somebody who put that in the chat.
Is that one of the things you can select on Match.com when you're building your profile? Like, is active methamphetamine use one of the check boxes? I don't know.
I get bored easy.
Brian, I had just a little, like, kind of a point on sort of a way to interview or question him. If he says that without the marijuana, I have these overwhelming methamphetamine cravings, one of the first questions I would ask is, was there ever a time where you weren't smoking marijuana and you didn't have methamphetamine cravings? And if he said no, that's never been the case, I'd ask, was there a time where you weren't smoking marijuana and it was even just a little bit less bad? And what was going on then? So he might have these little kind of solutions, these ideas, the things that have worked for him in the past that you can begin to get at. And even if there was a time where the problem was a little bit less bad, that can oftentimes be a good place to start.
But it sounds like he has significant demoralization in the setting that he's regressed. He's living with his parents again, and they don't want much to do with him. So that has to result in some really feelings of not being useful and demoralization. And so having someone in the community that can be his advocate and see hope for recovery for him would be identifying who those people are that lift him up, that he feels better being around, would be helpful.
Yeah. The hallmark symptom of social anxiety disorder is a fear of negative evaluation. And so he lives in a house right now where he seems to be kind of consistently negatively evaluated. Not that he hasn't kind of stepped into that himself, but with some of his behaviors in the past. But if that's kind of currently happening, then that's definitely something that you'd want to explore by getting primary care behavioral health, or making a referral to mental health center or mental health Hennepin mental health clinic or something like that, because I think that that's something that very much, depending on the settings in which his kind of social anxiety disorder manifests, we'd want to target those. So some people might have social anxiety disorder and it's like kind of performance only, so it's only like public speaking. Other people, they do fine one-on-one, but larger groups are really challenging. And other people, they do okay when they can kind of get lost in a crowd, but one-on-one is really challenging. So knowing more about that would be helpful too.
Did we get the suggestion about volunteering?
Volunteering was mentioned. Where is that?
That he would feel valuable helping others. That would be great.
Yeah, that's a great idea.
And Valerie, would you mind just speaking to, so I think one, Diodon, I thank you for your comment about both the previous, although I'm not sure what the trauma support unit is, perhaps offline we can talk about that. But I agree, it's the willingness to not move out of it, to figure out how to change the environment. So I guess to that point, following up on Valerie's comment from Minnesota Recovery Connection, how would you connect somebody, and is that like a statewide resource, or is that just in the metro, or how do you connect with the recovery navigators?
The recovery navigators are here at Minnesota Recovery Connection.
And that's in the metro, Valerie?
It is. The recovery navigators come from Recovery Corps, which is part of AmeriCorps, and they're in the process of spreading across the state. They have a person in Little Falls right now, and there will be more spreading across the state, but that's the idea. They're trained as peer support specialists here at MRC, and they'll be spreading across the state.
And could you remind us how to access those people?
Contact Minnesota Recovery Connection, and we'll hook you up.
Great. Yeah, sure.
I'm sorry. I went to the TBI event yesterday, and the speech language pathologists are really helpful in a lot of these aspects. Since he's not willing to address his substance use treatment, maybe going more the TBI route he'd be open to, and then they can work with some of the cognitive issues with work and moving forward.
That's a great idea. So if you couldn't hear that, maybe trying to find the hook to motivate him for change. Maybe going the TBI route and getting him connected with the traumatic brain injury clinic, where he might have access not only to psychology but also to speech pathology. They could be very helpful if some of his kind of social concerns and anxiety around, is around public speaking or interacting with others. If the TBI is at all related, they could address that. And also just getting practice in those areas, I think, is really helpful. And doing so kind of with the support of somebody like a speech pathology professional could be helpful. So great suggestion. It's awesome.
All right. It's time.
Okay. All right. So we are at 12:15. Or sorry, our clock hasn't been changed. We're at 1:15. Right. We'll change the clock. Rox, sorry. So if you need to go, that's great. Thank you so much for calling in today. If you have any other questions, we won't hang up quite yet, so that you can stay on if you'd like. Be sure to submit us your name via the group chat or email us so we can make sure we get you your CMEs.
We'd love to have your cases.
Yeah, we'd love to have your cases. So if you have a case in mind, we're a very chill group of people. You're not going to get it wrong. Please feel comfortable to submit a case to Roxanne, and we'll help you work it up. We have a lot of fun doing it. So please, even if you think, I don't know if it's a good one or not, just send it in, right? And we'll go from there. Okay. So please stay on if you have any other questions. We'll kind of be here before we hang up. Otherwise, have a good one. We'll see you next week.
Travel safely, everyone. Thank you. Good job. Good job.
Marshall has a
Marshall, yeah.
And Cam, we just wanted to remind people that Charlie is actually going to be on our Echo next week on Wednesday talking about stimulants.
Yeah. All right. So is he coming there live in person like some other people do sometimes?
No, you're the only cool one.
Yeah, you're the only cool person.
I'm the only cool person. Although Charlie did Facebook friend me, so I feel like I really made it. Yeah, so Charlie's going to be next Wednesday, 12:15, Little Falls Echo.
Yeah.
Yep. And if you want to access it, you just Google Little Falls or CHI St. Gabriel's Echo. It's the top thing that pops up.
Awesome.
And there's
Awesome.
a contact list.
We're going to try and do a better job of getting each other's contact on things, but hopefully by next week.
Cool. Excellent. Marshall, you had a question?
Yes. In the case that Brian presented, do you think it's a factor that he's still living at home? And I guess what I mean by that is it possible that his boredom or his lack of motivation comes partly from the fact that he's still sort of taken care of? It seems like if a case like his was turned into some kind of a Hollywood movie, what would probably happen is that he would somehow have to solve major problems himself, either housing or work or something like that, and that would focus him and help him be more motivated, I guess. But in real life, maybe that's just too naive to assume.
I think it's a good point, Marshall. I mean, being at home could be like this thing that is not working for him and that he's got all kinds of feelings about. But I think also equally, without knowing the case, there's so many things we don't know about it. It could be anything. He could love staying at home, you know, and the parents could actually want him to be there. So there's just so much that we don't know. But I was going to say something.
Or he's failed completely.
That's why getting at the goal is so important, Marshall, because it's like we're kind of like, feels like we're looking for something like, what does he want? Where is he going? Where's the direction? And spending time talking to him about what his preferred future would be definitely time well spent.
Yeah. Okay. Thank you very much.
Okay. All right. And Haley, did you want to ask your question?
Yeah, I don't know if anyone's still on that would be able to answer or have
absolutely
with it, but you want me to reread it or?
Yeah,
you guys want to read the question?
so the computer left, and so you might just have to.
Okay. Well, the whole like methamphetamine induced anxiety thing was super interesting to me because like in my mind, if you abuse methamphetamine for a long time, you kind of fry your receptors, and that can kind of mimic like an ADHD symptoms, which I could see presenting as anxiety. I was wondering if anyone's like tried to treat that with ADHD therapies instead of anxiety type therapies. Like I've seen bupropion used a lot.
Yeah, I think Brian actually and I have had this conversation before too. Like using ADHD kind of stimulant-based medications is almost like a MAT for methamphetamine use disorder. And you've talked to Brian. I think you've had some. You've read some articles on that, right?
Yeah. So I totally agree with where you're going with that, Haley. In terms of like how to frame that.
Sorry, I gotta go, guys, because my daughter's got a concert. So,
got it.
Yeah. And my basement's flooded. I gotta go to a concert, and I have to vacuum out my basement. So, bye, everybody.
My dog.
To your point, Haley, I think before actually treating anybody with a history of methamphetamines with stimulants, I do generally really want to get neuropsych testing or like some really good solid evidence that they really do have ADHD symptoms, because it's really hard to tease out. But if they do, like I have had people that have gotten neuropsych testing or formalized testing, because there's some computerized ways to do that, or there's a variety of different avenues that you can approach that with. But for people that really do, oftentimes they'll describe a history of even when they were using methamphetamine, instead of really amping them up, they just felt like suddenly they were calmer. Like for the first time, it was actually relaxing to them to take methamphetamines, which is not what you'd normally think about. And particularly in people that have that kind of de novo, that's what they lead with. Like, I really like my methamphetamines because it really, for the first time, felt like I really settled down. Sometimes they may have had like a family history, sometimes of like significant family trauma or like ADHD symptoms in school, or kind of suggest that. In those cases, for people that really have like a defined ADHD and it is anxiety, oftentimes it's manifest because they just can't track everything. They just feel like frustrated with everything, and that drives the anxiety. I have successfully treated people. Usually I try to start with guanfacine, although I'll be honest, most people that have had a history of methamphetamine, guanfacine is like peanuts. You know, like don't even bother. Lots of people will push doTERRA. Honestly, I've had like 1 out of maybe like 80 people that have started on doTERRA that ever thought it was helpful at all. I usually just jump and bag it. What I often my go-to right now is and there's some controversy in the field about this, but what I generally go to is methylphenidate, whether it be a shorter or long-acting methylphenidate, so like Metadate or Concerta, or just in smaller doses, immediate release. And I use methylphenidate specifically because it won't flash positive on an amphetamine immunoassay. That way I know very clearly if something comes up positive on the immunoassay for amphetamines, it's more likely that they're getting something else and it's an abuse situation. I know several psychiatrists that if they have a history of methamphetamines, the only thing that's really going to be that significant and helpful is going to be a relatively moderate to high dose, long-acting amphetamine salt. So people go towards Vyvanse. That said, why I don't like that is just because then I have no idea what they're using. They could be abusing amphetamines, and I have no idea because there's no like level that's meaningful. And so for me, it becomes a diagnostic dilemma of how do I really differentiate in that case. So for me, I stick with the methylphenidate. Is it going to be as potent? Probably not. That said, I think one of the things that I always lead with if I am going to go that direction therapeutically is having upfront, how am I going to define success? Because oftentimes people feel like I always want to have more concentration. Like I recently have a guy who's having that same issue and he's like, well, I just need to be able to study for 5 hours straight sitting in my chair. And I'm like, nobody can do that. But that's what his view is. I just need to take more and more stimulants in order to get to that. But that's what he's shooting for is normal. And I think that's when like, we just have to redefine what normal is. But I think your point's really well taken. It's just trying to really tease out what the specific diagnosis is the hard part.
Thank you. And that's why diagnosis is not my specialty.
Great question, Haley. Thanks, Brian.
Cool. All right. Well, thanks, guys.
I need it.